Hello and namaste and good evening or good afternoon wherever you are. It's a nice sunny day here in England, in spring in April. So I have a great pleasure to welcome you all to the sixth webinar in this series on maternal mental health literacy in India. It is one of the most neglected topic in India and also in the rest of the world in relation to maternal mental health literacy. So we have two distinguished guests, Dr. Anjali Viswanath and Dr. Fathima Thasneem here with us. And I'll introduce them both in a minute, but let me just say a few words about myself and the project that we have in India. I'm Raghu Raghavan. I'm a professor of mental health at DeMontfort University in Leicester in the UK. And I lead a UK Research Council funded project in India on mental health literacy in rural and urban communities. This is primarily a project that is actually based in Kerala, mainly because of the fact that even though the human health index of Kerala is pretty high in par with the rest of the world, there is a higher incidence of mental illness and suicide rates in Kerala in comparison to other Indian states. So this is a project that actually looks in a different way. We are using theater, cinema, and many of other methodologies in terms of enabling, engaging, empowering, and participation with communities in Kerala. So we work predominantly in four districts. In Ernakulam, in Palakkad, in Kozhikode, and also in Malappuram. That covers about 16 million population, 16 million people, the half the population of Kerala. So we also have in this project, we also have partners from the UK, from colleagues from the DeMontfort University in Leicester. We also have colleagues from Loughborough University in Leicester, and University College London, Middlesbrough University, and also we have theatre partners from Nottingham. In addition to that, we also have people colleagues from the Tata Institute of Social Sciences, and we also have colleagues from the National Institute for Mental Health and Neurosciences, NIMHANS, and we also work with two main NGOs, the Mental Health Action Trust, which is based in Calicut, and also MeHeLP Foundation, which is based in Kochi. We also work with Chandradasan, the Logadami Theatre Group based in Kochi in relation to some of our creative arts and participatory engagement. So great to have you all in this webinar, and we will normally talk for about 40 minutes and we would then be open up for questions. So hopefully we will finish within an hour and a half, depending upon the engagement activities we have. This webinar is also streamed live on Facebook, on the MeHeLP Facebook page as well. So why mental health and why mental health literacy? Because mental health literacy is one of the key issues in relation to how we inform people about mental health and well-being and the way people can actually access and services, etc. So what is mental health literacy? Mental health literacy is not just mental health awareness. Mental health literacy is actually a key component of that knowledge and skills that we require. It mainly consists of six different components, mainly kind of our ability to recognize the specific disorders or different types of psychological distress. Secondly, it looks at knowledge about risk factors and the causes that might be applicable in relation to mental illness and mental health and well-being. And thirdly, it looks at knowledge about self-help care and self-care interventions. And fourthly, looking at knowledge about professional help available and your awareness of it. And fifthly, and most importantly, attitudes that facilitate and promote the health recognition of mental distress, such as the eradication of stigma in relation to mental illness. And sixthly, knowledge about how to seek mental health information, because often people don't actually access help because of the fact that they don't know how to seek information, what is the right kind of information that they require for that. And low mental health literacy often equates to the higher amount of stigma and lack of people actually accessing mental health services. So that is the sense of the project that we actually do in relation to how we promote that in rural and urban communities. And do follow us on our Facebook and Facebook page, and also on our YouTube in relation to the various activities that we do. So now I have great pleasure to actually introduce our two distinguished guests, Dr. Anjali Viswanath and Dr. Fathima Thasneem. So let me just introduce Dr. Anjali Viswanath first. Dr. Anjali, after taking a degree in medicine, she has completed her MD in psychiatry at the Government College in Thrissur, and has worked as a senior resident in the Department of Psychiatry and also at the Government College in Thrissur. Dr. Anjali is currently working as a consultant psychiatrist at Starkey Hospital in Calicut. She is enthusiastic about research, and she has also conducted research on geriatric psychiatry and substance abuse. She has also rendered expert mental health care and support to COVID patients and their families during the pandemic. I understand is actually still continuing in high density in India, and whereas we are just coming out of it, so obviously that is the case in India. Now, a great pleasure to welcome Dr. Fathima Thasneem, gynecologist, a consultant gynecologist at Calicut District Cooperative Hospital. Thank you both for joining this webinar on an important theme, that we often don't talk about in terms of maternal mental health literacy in India, and how we can actually talk without any barriers about it, how we can actually mainstream that conversation around mental health and well-being of mothers, and how we progress in terms of improving that mental health literacy. So I have asked Dr. Anjali Viswanath and Dr. Fathima Thasneem to say briefly about their own respective areas in terms of how it might actually relate to maternal mental health literacy. So can I ask Dr. Fathima to first of all talk about your area in terms of maternal care and how mental health literacy is actually related to that.
Thank you. First of all, thank you for this webinar. Very rarely we get to have a webinar in connection with the psychiatry people. Mostly we have this gynec infertility and laparoscopy. So thank you for that. When coming to maternal health, we have to realize the fact that the stress upon pondering into the mental health of all your pregnant patients, it has been only coming up recently. For example, the Bible of obstetrics that we study during our post-graduation as Williams textbook of obstetrics being published from United States. It has until now 25 editions, but only last 2 editions, as the 24th and 25th edition only have got a chapter exclusively devoted for the maternal mental health. So that's the evolution. Even though there has been 25 editions of this, such a big book, only 2 editions have got a dedicated chapter for the psychiatric issues of our obstetric patients. So all of us are in the path of evolution when it comes to maternal mental health. And it is good that recently we have realized the importance of knowing the mental status of your patients and looking into it, educating them and supporting it. So we are also in the evolution process, learning more about it. So we all know during our study time and also during our practice, we have 3 terms. As a gynecologist, we have the 3 terms: postpartum blues, postpartum depression, and postpartum psychosis. But there are more things into it, like the kinds of anxiety, parenting stress, and all these terminologies are newer for us from the perspective of a gynecologist. So we have, all of us have started to inquire into it. When it comes to Kerala, the issue is, as Sir had told earlier, the density is high, the population density is high. So we have, any gynecologist have an average number of like some 20-30 OPDs that they are catering to per day, apart from the work they are doing in the labor room, apart from the work they are doing in general gynecology, it's the non-obstetric gynecology and infertility, all those things. So the time that we devote for each patient is little less. So when the time is less and when we are hastily going into the physical examination, obstetric examination, we tend to leave the mental health evaluation most of the time. And in most of the centers, we don't have, as I told, it's in the evolution process. but still we don't have a counselor sitting at the obstetric OPD. We don't have a counseling room where they can talk more easily. We don't have a person who will do the risk assessment and identify the patients at risk of anxiety, or those patients who might develop mental disorders, who are having some flares of possible mental disorder in the future. So these things are not actually happening in all OPDs unless it is a tertiary setup or a education setup. So recently, we have started realizing the importance, and recently we have started to discuss with the hospital managements, clinic managements, especially in the private sector. We have started to employ a person, a counselor as such, who is devoted for this and understand or talk with these patients and understand what are their issues. Especially because our population is more educated compared to other part of India, most of these people have got stress related with their work, and also because all these females participate in the financial structure of their family, they have that background stressors. So these things always come into play when we are dealing with a high literacy, high density population as such in Kerala. So these are the aspects that as a gynecologist we tend to overlook, but we have to focus upon. That they will be having a background financial stress which they might not open up with us. They will be having a stress of being a small family, which is very common nowadays in Kerala, especially in the cities, and especially during the COVID time, because all of them are restricted to their small nuclear family setup. So those things are also coming to play. And today, nowadays, females are in the path of getting better education and getting better jobs against the family demands. We are not as modern as a Western society where they have the right freedom to take their own decisions regarding their life and their future. We have not reached that set standard, but we are still in the process that all females are getting educated and conscious of their job and conscious of their financial independence. So all these females have got that background tension, which sometimes they'll not reveal to us because they might be sitting with their mother-in-law in the OPD, or they might be sitting with their husband in the OPD. So those things we have to take care. So as a gynecologist, all of us young gynecologists, especially the budding gynecologists, are these days reminding ourselves every day that we have to ponder into these things. We have to just 1 minute extra apart from the routine obstetric examination and routine caregiving. So that's what, as a gynecologist, I have realized. And also, I'm proud to say that the Kerala government have initiated the Amma Manasa program, which they have imparted into the national mental health program as well as the maternal health program. So that is underway. They are adding the implementing programs as part of the Amma Manasa, wherein the government is specifying that we have to get a psychological counselor in the obstetric team. So that is one thing that we are in the way to betterment of our standard of care. And then another thing is that our private hospitals were all this time the private hospitals, like it was even though they are private hospitals, it was the structure and the function was like of a semi-governmental, unless it is a high-end, high-class hospital. That's like middle class and lower middle class people are going to a private hospital, which is a little different from the government setup. So that is in the process of revamping these days. Most of the private hospitals are modifying their obstetric units as a dedicated obstetric unit with all the pomp and show of enjoying the process of birth. So that philosophy is being inculcated recently. Earlier, it was like come, deliver, and go, just as any other patient comes to the hospital to treat a disease. But nowadays, we are making people realize that you are not coming to the hospital with a disease, but you're coming to the hospital with for a very good experience that you're going to have in your life. That is giving birth to a baby, adding a member to your family. So that concept is being evolving these days into at least in the private hospital. So obstetric department as such as the feel good is different from other departments. All other departments are like treating departments. Obstetric is like taking care departments and giving you a feel good department. So that thing is coming up. We are having birthing units are coming up where we give all the support system wherein the lady feels that she's doing something great. So that feeling is most important as as far as the obstetric patient is concerned. So they are having that lightness of the whole process, and the minor cases of postpartum depression and postpartum blues can be overcome with these kind of approach. That's what I feel as a gynecologist. So we are all in that process, changing our birthing unit to a more sophisticated, more inclusive unit, so that they have that easy feeling, feel good feeling. They are going back home with a sense of achievement that they have done. They have given birth to a baby, like that, and also trying to reduce that parenting stress, that element of parenting stress in the initial 3 days. I think we are able to reduce it. But then after the 3 days until 40 days, when they come back to us for the checkup, that time still it's a great time that we are not able to do anything from our part. But then as part of the Amma Manasa program, the junior social workers and JPHNs will be more involved in taking care of these women in their immediate postpartum period. That's 6 weeks when they are not contacting a doctor in a normal pattern. So that's it in the obstetric part, I feel, to begin with.
Thank you, Dr. Fatima, for trying to outline the way maternal health services are actually orientated there, and how, and the importance of maternal mental health care in that context. Now, I would like to turn to Dr. Anjali Viswanath in terms of an expert psychiatrist in relation to how the maternal mental health care is actually important in Kerala, and also both in the Indian context as well.
Thank you, Dr. Raghu Raghavan. I'm so glad to be with Dr. Fathima Thasneem. And thanks for inviting me for this webinar session. And I'm also happy to be a part of this project. So as Dr. Fathima Thasneem told, pregnancy and childbirth is supposed to be a pleasant and a significant period in a woman's life. But it is not so for everyone. At least some women faces the mental health challenges, and it is occurring when they totally not expecting such a challenge during their pregnancy period. So it is told that 1 in 5 women suffer from mental health issues worldwide. And when come to India, like a country with a low and middle income, the magnitude is much high when compared to high income countries. The statistics says that it's almost 15 to 16% of women during pregnancy, and 19 to 20% of women after childbirth suffer from mental health disorders in a low and middle income country. When compared to a high income country, it is only 10% during pregnancy and almost 13% after delivery. So we can see the difference in the magnitude of the issue and the need for intervention. So at least in our part of the world, like when a lady becomes pregnant, a lot of preparations happen, like the family prepares, the lady prepares, baby shower, a lot of preparations happen, especially concentrated on child rearing practices and their physical health. But unfortunately, no one cares about the mental health of the lady. No one prepares for the mental health of the lady. Everything happens, every preparation goes in terms of physical health and child rearing practice. So why is this happening? There is definitely a gap in terms of awareness of maternal mental health. So why is there a gap? That is a question which arises, and the most important reason might be the asking for help can be hard for the women. They will not be able to come up with their issues, and the reason for this might be a lot of myths and misconceptions happening about pregnancy. There is something called pregnancy glow, like it is thought that pregnant women should glow, and there is something called good mothers and bad mothers. Good mothers are usually happy, and they never have a nervous breakdown, or they never have a mental health breakdown. They'll have to cope up with the issues by themselves. It is the society norm, like good mothers take care of the baby without any mental health issues. So due to all these issues, the ladies fear about the judgment. They fear about taking away of the child, and they fear about being called as crazy, and so they do not come up with the issues. And second thing might be, even if they pick up that something is happening, and even if the family pick up that something is going wrong, they do not know where to go. as Dr. Fathima Thasneem told, a program like Amma Manasu was launched recently, and a lot of workshops and training was given for ASHA workers, junior nurses, etc. before the pandemic, and a lot of effort were taken for that. But due to this pandemic issue, we could not implement it practically. And the district mental health program is looking into it seriously, and we hope that after the pandemic ends, will be able to come up with more and more services with Amma Manasu. So, what are the main mental conditions that are likely to be faced during pregnant period? The first and most thing is a lady who is already diagnosed to have a psychiatric disorder becomes pregnant. A lot of questions comes in her mind. Do I have to take medication? Can I stop medication? Is it safe to have medication when I'm pregnant? Is it safe to breastfeed the baby when I'm taking medication? So a lot of questions happen. Usually what happens is that the lady stops taking medication by herself. So the first and most thing what they want to do is they should come for a pre-conception counseling. They should get a review what they should do in their pregnant period, and they can medications and the doses can be adjusted accordingly. And second thing is newly diagnosed psychiatric conditions during pregnancy. As I told, it's very common. There are, as Dr. Fathima Thasneem told, postpartum blues, postpartum depression, and postpartum psychosis. These are commonly discussed. Apart from that, there are many conditions. Briefly talking about postpartum blues, it is the most common constellation of mood symptoms that occur during pregnancy, and it is almost 50 to 80% prevalent in pregnant women, and it is very transient. And usually the onset is on the third day, peaks by the fifth day, and subside by the 10th day. So when the onset is third day, usually the female gets discharged. So there is no chance for evaluating that condition. So it goes under diagnosis or unevaluated. And as it is very transient and self-limiting, only what is needed is psychoeducating the lady, reassuring the lady, validating the feeling of the lady, and being with her. And we have to closely monitor whether the symptoms are worsening or whether the symptoms persist beyond 2 weeks, which we have to look for postpartum depression, which is a much more serious condition. And talking about the prevalence of postpartum depression, it is almost 15% prevalent globally. And when talking about Indian statistics, almost 22%. And a recent study conducted in Calicut Medical College, it's about 26.7%, which is a huge amount which needs intervention. So the symptoms include feeling low, feeling not very well, fatigability, difficulty bonding with baby, and it becomes serious when there are thoughts of committing suicide or harming self. As told earlier, suicide is a leading cause of death in India. And when talking about mortality rate, compared to other Indian states, Kerala is having least rate. But when we talk about maternal mortality causes, suicide is the third most common cause of maternal mortality after postpartum hemorrhage and preeclampsia. So this makes the condition serious, and the need for intervention is warranted due to this condition. And next comes the postpartum psychosis. That is a rare condition. Only 0.1 to 0.2% of population, pregnant women suffer from postpartum depression. But still, it is an emergency. It is a medical emergency. It is an obstetrical emergency, and it's a psychiatric emergency because there is a risk for suicide and infanticide. Infanticide is about 4% in postpartum psychosis, and suicide is about 5%. So we have to closely monitor the patient for going for such a devastating process. And the next thing, least talked about, like anxiety disorder. Anxiety is also very common. Antepartum anxiety is an important predictor for postpartum depression. So assertive screening is necessary for picking up anxiety in the antepartum period. And when it comes to anxiety symptoms, fear of cord death is very common among women. That means a lady fear about being dead in the delivery table or being dead in the operation table. That is very common when it comes to pregnancy. And there is something called nocturnal vigilance. The female gets up all night and look whether the baby is breathing, whether the baby is moving, whether the baby is alive. So these are all some symptoms of anxiety. And PTSD, OCD, these are all very common in pregnancy. So we have to fill this gap. We have to find out where the barrier is. When we talk about barrier might be at community level. It might be the stigma, as I told earlier. It is a complex barrier which prevents the family from seeking help because they fear about the gossips and the discussions that will go on in the community if they seek help. help. And the next thing will be lack of awareness of these much conditions that may arise during pregnancy and the potential for treatment. So people does not come forward with these issues. They think that these are the normal physiological changes in pregnancy and it will go away by itself. The lady itself can control the negative thoughts. That is the thought which family and community has. Next thing is, as she told, the lack of infrastructure and time constraints and heavy caseloads. It is definitely a barrier because there is no time to check the mental health status or mental status of the patient during regular antenatal visits. But the DMHP is extending its service now, and we are approaching for a stepped care approach. That is, the frontline workers will pick up the common conditions like psychosocial issues, interpersonal issues, and they will intervene at their level. And more serious and severe conditions will be referred to specialists, and some non-specialist doctors who are specially trained also will be available for the service. So we are expanding our services through DMHP. So that is, we have to barriers, definitely the barriers, we have to tackle the barriers. There is a gap in terms of awareness and also in terms of access of services. That's all about a psychiatry point of view.
Okay. Thank you, Dr. Anjali, for that, outlining some of the key issues in relation to people's awareness and some of the challenges that they actually face. You mentioned an important point in relation to family. Family is understanding, individuals' own understanding, and the family's own understanding. In a state such as Kerala, where there is a higher literacy rate, I'm still surprised to see that the family awareness of what some of those issues in terms of both anxiety and depression in that particular context, the maternal context, is very, people are not aware of it. Can you sort of shed much more light on it?
Yes, the literacy rate is definitely high in Kerala, but there are some cultural norms which exist in the society, and the family fear about what society thinks about their family mental health issues. And usually, what happens? The common question faced by a pregnant woman who express her mental health issues: "You are having a baby. Why are you feeling depressed? How can you be depressed if you're having such a beautiful baby?" So that is a very common question that is faced by a woman. And another thing is, we have given birth to more than 2 or 3 children. We never had this issue. Then why are you coming up with these issues? So these are commonly faced by pregnant women in our part of the world. And I personally have heard this type of comments from the bystanders. Recently, a patient was admitted with postpartum psychosis. 3 or 5 hours after delivery, she was having psychotic symptoms. I tried to psychoeducate the family members regarding the chance of infanticide or harm to the baby. She was very adamant and she was not taking care of the baby. At that time, the reply what I got was, she's not a lady like that. She's a family woman. She will take care of the baby. She will never do that. They are not able to accept it. They are not able to accept it as a disorder. They are thinking it is something like mind is a different thing from body and it is happening due to some external factors. They are not able to understand it in the magnitude of illness. So it definitely in Kerala, even though it is a literate state, there is a lacuna in understanding about the psychiatric illness, and the stigma it is very, very much compared to urban areas. In rural areas, there are some myths called like those ladies who deliver to C-section is considered to be abnormal because she has not faced the difficulties and she did not suffer the pain, so she cannot be a good mother. These myths and misconceptions do persist in our society.
Okay.
So recently we had an issue, right? Recently we had a case of infanticide, which was very much, the news was almost everywhere in all social media sites. And in Facebook itself, we saw that the comments that came below the news was like, the majority of the comments were criticizing the woman for being not a normal mother. It's like people are not realizing that there are certain spectrum of mental states when this woman unknowingly is doing these kind of mishaps, happenings, but then people are not understanding. And there were so many doctors coming up educating against these links just recently, maybe 1 month back. Please don't comment like this. It will not be, don't judge like it. It is totally different scenario. But then it's only in the budding state. People are just realizing that there are certain things. It's just very much in the budding state. I should say the mental literacy is very low when it comes to, especially when it comes to pregnancy and childbirth. And also the other issue, these women as the elder ladies in the family, they might have had a successful management with all their deliveries, but they might not have had the stress of jobs, the stress of financial responsibility, and the stress of taking care of a domestic responsibility single-handedly. So these things are overlooked always. But then the elders always come and say that you have been taking care of yourself. You are elder. You might have, we all delivered at 16, 17 years. You are delivering at 25 years. When we are delivering at 30 years, in spite of being so aged, why are you not able to handle all these things? So those questions is also very, 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 very common. And also the fact of she might have had an infertility treatment. So in the background, they'll be always thinking that having had a treatment for infertility and my baby is born out of a treatment. So that those babies are a little different from naturally conceived babies, which they might not reveal to the extended family. Only the couple might be knowing they have had a treatment. So how to deal with that? Is my baby normal? So those women will be always tense whether my baby is normal, just like the normally conceived babies. Whether my IVF baby just, or even just simple medical induction tablet given for one cycle. Even for that, there are things like they sometimes they ask to us, Madam, if you are taking all these tablets and conceiving, what will be the quality of the baby that I'm going to have? So that's also infertility is very common these days. We give treatment for almost 1/3 of the pregnancies are some sort treated pregnancies. So they have that tension which they will not reveal to others. Revealing is also a stigma. That adds up to all these issues.
Yeah.
Medical literacy is very less, even though the general literacy is very high. That's what I told. Even for the doctors, we are also in the state that we remind ourselves 1 more minute extra for pondering into the analyzing the risk factors for antenatal depression, as Anjali was telling, so that we might help her not going into severe disease from the antenatal period itself.
Yeah, thank you for that. I think it's important. I think you outlined, both of you outlined a number of factors here in a stigma, family life, and also the kind of role of men and husbands. And I think that is often an ignored area, because men, how, especially in a culture of India, really, how men play a supportive role in that context, regardless of they are actually at work or breadwinners of the family or whatever. There is still a responsibility in terms of how they actually provide that support to their partner, and how that is actually being done. I think that very much depends upon the awareness of the husband.
Thank you for pointing out that aspect. For all these situations, we are in a stage of evolution. We have not attained the standard of a Western society where the nuclear family is very much interdependent. Here, the family is nuclear, but when it comes to pregnancy, parents or sisters or someone come in, join them to take care of the baby, and the male partner is almost always eased out of these responsibilities. Let them go and do their work. Let them have their mental security. Let them be at peace. Let not the baby getting up at night disturb the father because he's going to work. All these things. So most of the time, even if it is a nuclear family, during the postpartum period, it is not a nuclear family most of the time. Or sometimes they'll be having a maid or ayah just exclusively for taking up this mother and child. And there is a period of separation between the wife and the husband. So that also most of the time adds on to the anxiety of the mother. She'll be like, my husband is away from me. I'm not having the proper relationship with him. She's not getting a privacy with her husband. So she's not able to talk properly with him. So that is very much prevalent. And that may be due to the emergence of paternity leave. Some males are getting to be with their newborn and the new mom and spend time with that. But most of the males are not, most of the husbands are not able to do that. And they do not know that if they provide a little extra time for their wife, maybe it might erase some of the tears from her eyes, unseen tears from her eyes. Most of the time, there'll be some unseen tears, unseen anxieties, getting into cries very easily that she might be hiding it from others. So that is very common. And that paternal education and awareness is very less when it comes to taking care of the new mom.
Dr. Anjali?
Yes, when it comes to paternal awareness, even if they're aware, they have a privilege of doing a job. As Dr. Fathima Thasneem told, usually it is the parents which take care of the female when she becomes pregnant. But the lady will surely wait for husband to come. She loved to be with her husband, but that is not happening most of the time, and that is the reason why a lack of partner is an important risk factor for psychiatric illness during pregnancy period. And also partner violence and domestic violence add on to the risk factors of psychiatric illness during pregnancy period. And usually the household chores and child rearing practices are done by the lady only. Even after the delivery of the baby, the male partners will never take up the role of the mother and do the child rearing practices or household chores, which add on to the burden and which make them to neglect their own health and mental health. So definitely there is a need of awareness among the male partners. They think it is, yes, pregnancy is a physiological process, but there are some abnormal mental health issues which happens during pregnancy. They should be aware of that, and they should come forward and help the partner in all the household chores, child rearing practice, and also the physical and mental support is needed for them.
Yeah. So I think that is also a factor, the partner not being there. That's particularly true in the Kerala context, where many of the partners might be on migration, economic migration to other countries, but they are not actually near by their wife when they really require that support most.
Yes.
And I think so. Can you could you care to comment on that, because that is a special context in many places like Malappuram and many other areas where that is actually predominantly is actually happening.
Yes, most of the partners are working abroad, or they'll be away from the family, but they are supposed to be the breadwinner of the family, and they are spared because of that. They have to work, they have to earn, then only I can look after the family, the baby. I can give a good health service, like a good hospital, the good doctor. That is the norms given by the society. Men are to work and earn, female have to breed and look after the family. So that is being carried now also. So in the terms of earning, they go abroad, and for the economic gain of the family, they are away from the female, and this will add on to her physical mental health issues. And there will be hormonal change during pregnancy. Even if it doesn't go to an disorder level, she will definitely need extra care, extra support, extra reassurance during pregnancy period. That is often lacked due to this separation of husband and wife. And also there are like after 7 months, the lady is supposed to be in her own home, and the husband should to stay in his home. They should not stay in a room together. There are some norms like that also. So we have to psychoeducate and make them aware that importance of partner in mental health of pregnant women.
Also, because as sir just point out, because the husband is abroad, maybe in other country, because of this job issues, and also during this pandemic, they might have been not able to come because of the fear that if once they come, they'll not be able to go back. So that is more, it makes us more responsible as a caregiver to counsel the family, because we cannot ask the husband to come back and give support to the mother. He cannot just go away with his job like that. So it becomes more important from our part as the caregiver to counsel the elder people and other people at home. See, the female is alone, her husband is not there, so take care of her. She might be having some blues, she might be having some stressors in mind that she might not be talking with you people. Have time to talk with them. So that makes our part more crucial, in especially in this pandemic scenario, because most of the time, almost 50% with my experience, even if the breadwinner is is an expatriate, they might come for at least 1 week or 2 weeks to spend with their newborn baby and wife. But because of the pandemic, they are not able to come. They will have to say, you just deliver, I'll come, you will join maybe after this pandemic. So at this point, we have to realize that we have to be more contributory in such a setup.
Yeah, that's true. That's true. And I think there is that cultural factor that there is that, even though in the looseness of the joint family systems and everything that's going on, there is still that strength. And I think that is still a strength that India has, whereas in the Western world, we don't actually have that. If a mother is on her own, if that is the case, because you don't actually have that. And I think that it is actually indeed a strength, and that should be looked upon as a positive thing rather than as a negative thing.
Yeah, we have to tap the positives from that. We will be doing the role to tap it.
Yes, that's right. So, what are the kind of best ways in which that we can promote maternal mental health literacy? There are two arms to this thing, really. Obviously, one for women, for mothers, young mothers, or about to become mothers, and also for their families, including their husbands and others as well, really. Because obviously, there is always this mother-in-law factor that plays out here. It's not just in India, throughout the world, that is a factor in this kind of context for the well-being or not so well-being of the wife, really. So I think we can indeed try and look at that. Can you care to comment on that?
Yes. Yes, we can. We can overcome it by a proper screening technique. Proper screening can be done during antenatal visits. Only if we know the true burden of the problem, we can intervene it. At present, what is happening is that there is no proper screening. We don't know what is the true burden that we are facing. So we have to screen it properly. In my opinion, it should be open and to the lady rather than ticking the boxes like do you have this, do you have this, just ticking. Rather than that, it should be open ended questions, and we have to probe from that, probe for her mental health issues. So if there is a proper screening technique, if we can pick up the risk factors, and we can if we can pick up all those who need help, extra care, we can concentrate on them, and we can psychoeducate them and their family. It's not possible to to psychoeducate and counsel everyone who comes for antenatal visits, because the caseload is very high in a country, in a state like Kerala. So we have to pick up this. Proper screening should be there, risk factors should be identified, and all those with risk factors should be properly counseled and properly psychoeducated. And the females should be assessed singly, like alone. Most of the time we see that whenever, as sir told, whenever a mother-in-law or anyone from husband's family is there, she'll be perfectly okay. Okay, I'm okay, nothing wrong, I'm perfectly okay. If we ask her personally, she will come up with lot of issues, and she will tell us also, don't not to say this to the family, because she fears the family's response to her opening up of her mental health issues. So definitely mother-in-law, family, everyone's need a preconception counseling. So these are the issues going to come during mental health, during her pregnancy. These are the mental challenges she's likely to face, and they should definitely need a counseling. So we have to separately address the issues of lady alone, rather than along with her family members. And we have to pick the areas, hot areas, where the intervention is needed. If it is a psychosocial issue, if it is an interpersonal issue with mother-in-law and the lady, which add-ons to her mental health issues, we have to intervene that, which will help to better her mental health.
Dr. Thasneem?
Yeah, earlier this physical education, that is the antenatal exercises, it was very rare during obstetric practice. But for the last maybe 5 to 10 years, this awareness about antenatal physiotherapy has increased. That was because some units started mandatory physiotherapy visits during their obstetric monthly visit. That's like in first trimester, did you go to the physiotherapy? So the patient is like, they are supposed to go get a tick mark in their antenatal chart. So gradually it became like people will ask us in some centers when there is no facility for antenatal physiotherapy. These ladies ask us, madam, can I do these exercises? Madam, can I do that exercises? Like that. So the same pattern of evolution should happen with this mental health also. Like initially, we can have a mandatory counselor visit during the monthly obstetric visit. That they come to us, they go to the vaccination unit where they have their tetanus, TB, tetanus, diphtheria shot. And then they go to the physiotherapy unit where they learn about the kind of exercises that they can do in your first trimester, second trimester, and third trimester. Meanwhile, this way we can ask them to have a visit with their counselor. Just go talk with the counselor. The counselors can sometimes pick up something with you, or you can just have a chat with the person. She might be helpful when you are in labor also. So once we, all the gynec units, all the obstetric units start this mandatory counselor visit, gradually it will become a norm. Then people will start asking us, just like they started asking about physiotherapy. Earlier it was like, what physiotherapy? You go do your kitchen work. What is it? That is enough. Do washing your clothes, everything. Do sweeping. That will help you in aid you in normal delivery. That concept has changed over years. Likewise, we have to change the concept towards the mental health also. So we start in all obstetric units. These days we are in that path. We are starting that mandatory counselor visit in every trimester, and gradually people will have an awareness. See, I should have a research counselor visit. No, am I supposed to have that? The people ask. Maybe in five years to come. Hope so.
Sure, sure. And I think what is important here is actually we should not medicalize the whole maternal health here, because obviously the maternal health, childbirth is already medicalized in that context, really. And I think we don't want to medicalize over too much in terms of, I think, how can people rely on, because the power is actually within you. And I think that, in terms of own positive psychology, in terms of how we can actually develop their own skills, knowledge, etc., and also seek support from people like counselors, the families, and the medics and other people as and when required. Because I think otherwise there is the tilting too much to the medical angle might actually think that everything is outside. And I think there are things that we should be taking care of ourselves and then seek professional help and support as and when required. That it is the right process, really. I think that's very important.
Also we give a pediatrician visit during the late pregnancy, which was not practice in the earlier days. But these days we have started sending all these patients, especially the primary gravidas. Go meet your pediatrician. You're preparing to be a mother. You're giving birth in another 2-3 weeks time. So discuss with your pediatrician what all you can expect. Sometimes your baby might be in the ICU, which is quite common. It is not that just your baby is in the ICU, which is one of the factors that will lead to the postpartum blues and anxiety. So go visit your pediatrician. He will tell you or she will tell you about what you can expect. There can be neonatal jaundice. There can be why the baby is crying. So the lady is mentally prepared what all to expect, what all challenges that she will face in the immediate first 2-3 weeks. So she can gradually adapt to that change, sleeping pattern, all these things. So pediatrician visit is during the late pregnancy is also an important aspect, I feel, aiding to relieve the tension.
Okay. Thank you for that. I think we will take a question now. I think there is a question in the question and answer. This is a question by Renu Nachal. Young women are overwhelmed with responsibility of looking after newborns. They seem to have little awareness about the challenges and the changes that the birth of a child can bring to their own lives, particularly the loss of control over their environment. This could lead to postnatal depression, and what kinds of support groups are available for new mothers, if any, and how to access them. Dr. Anjali first.
Talking about a support group, like a state like Kerala, we doesn't have a group like that. But what we can do is there are multiple visits after her delivery, like postnatal period. There are multiple visits to the hospital, and there are some breastfeeding classes that is taken by the junior nurses and ASHA workers. We can impart some information during that classes, and they'll get some information in that classes about this issues, mental health issues faced during this postnatal period. And unfortunately there is no support groups available now, but these are the ways in which services are provided. This breastfeeding group, and there are something called mother and child trafficking system, which is a digitalized system through which they get updates about immunization and other details. Through that system also some health awareness, mental health awareness tips can be given, but unfortunately there are no groups. As I know, there is no groups available.
The Amma Manasa program, So soon we will be developing
Yes,
with
yes.
the social healthcare workers like JPHMs and ASHA workers as the core. We'll be developing a
Yes.
group which will support the new mothers. I mean,
Yes.
maybe in 2-3 years that will be fully functional.
Yeah, it was fully trained. The ASHAs and junior nurses were fully trained with workshop. They were given dummy cases to diagnose. And due to this pandemic only, that became like a little slow. We will come up with the more programs associated with Amma Medicine. Kerala has taken a leap which can be modelized by other states regarding the stepped care approach to mental health.
Okay, okay, thank you. I think there is also the opportunity for mothers to formulate their own groups as well. You don't necessarily have to, there
Yes.
are other opportunities in this day and
Yes,
age,
yes.
with technology is wide, WhatsApp, Zoom and everything else that's actually
Yeah.
available. I think mothers can actually take the opportunity to actually connect with the other mothers they know, or other people who might be of actually help as well, in relation to, because of kind of peer support is actually essential, a factor that might actually help in terms of how to find solutions, and it gives you more opportunities of talking about people's experiences, etc. So I think that is widely be helpful in that context. So okay, Kerala, it says actually that Kerala needs to take a lead on this. I'm not quite sure what the Kerala. I think yes, it is. I think all states have to take a lead on it. In these matters really. So let's move on, and I think it's in relation to because it is, the thing is that there are wider social cultural factors that influences here as well, because any of these things is actually, it is not just the absence of symptoms. I mean, I think we are not looking at depression as a kind of, as a diagnosable state. It is something that one might actually feel, as Dr. Fathima and Dr. Anjali mentioned about, that you might feel sad and you might feel quite down or whatever really. And how can we kind of promote this? How can we mainstream this conversation? Why are people so reluctant? Why are mothers so reluctant? Why are women so reluctant in terms of talking about one's own mental health and well-being in the Kerala context and also in the Indian context?
That's because of the awareness, as we were discussing. The awareness is still on the lower edge. That's why we are, as whatever we could do as gynecologists, that's what we are trying to incorporate this counseling sessions as a mandatory part of the obstetric visits. So that at least once in the 3 months, every 3 months, every trimester, she is meeting a counselor with whom she just talk with them. So that sessions will should become a normal pattern. As of now, it's not part of guideline and it's not part of every obstetric unit. But hopefully, in course of time, it will become part of every obstetric unit. So that just like people nowadays ask us about physiotherapy, we forget to advise them. Let them ask us about mental counseling programs in case we forget them in the future. So that is that is one way we can increase the awareness to these people.
And sorry to say, in a patriarchal society like ours, women's health is usually overlooked. Even if they are not well, they are supposed to work. They are supposed to take care of the baby, and they are supposed to do the whole household chores without any help. So they themselves feel neglected. Oh, I have these symptoms. So that may be a normal thing. I am supposed to suffer this, and there is no relief from this. I will have to go through this. That is my life. That is the thought of every woman, most of the women in a state of Kerala, because of our society norms. So that may be the reason why they are not coming up with issues, and they fear judgment. They fear being judged as a crazy woman. They fear of the child. Like there are instances in which mother-in-law and the husband's family taking away the child because of the mother's mental health issues. They fear about such things. So that may be the important reason why they are not coming up with their mental health issues, which we need to address seriously. That is an important reason.
Yeah, and I think the media, the so-called media, all types of media, plays a major role in that, because obviously the media gives a very negative image of this, the whole thing really. In this developed area where people are very knowledgeable about things, we are not actually giving, the media is not actually giving the right information at all to the wider
We can
masses.
use the same media. We can use the same media to counter it. That's the loophole that we can have. So many hospitals are coming up with their short videos, awareness videos regarding this maternal mental health. Recently, we had a video by the Center for Infertility and Maternal Mental Cymer from Cochin. They had released a very beautiful video regarding maternal mental health, and it had a wider reach in Facebook and WhatsApp forwards. So we can use the same media to do our part also.
Yes, that's true. And I think
one time will come that we are succeeding in our job.
Yeah, but I think both the print media and the social media that are, has to be much more responsible in relation to how right kind of information, the right kind of networks and support are actually provided as well. So, okay, can we take another question here, please? There is another one by Anjali Viswanath. What can we suggest to a new mother who feels overwhelmed with the roles and responsibility of the child and find no support from husband and feel burdened? How can we help them as a professional?
Yes, definitely we can help them. First thing is that they should come forward and seek help. And there are a lot of methods to help them. So first thing what we do is we'll evaluate what feeling overwhelmed. Is it just a subsyndromal level, or does it goes into disorder level? That is the first thing we assess. If it is in a disorder level, she definitely need intervention in psychosocial aspect, non-pharmacological aspect, and both might need medications also. So first thing is evaluation. So my suggestion is come forward and seek a medical help, at least from a frontline worker who will be able to screen her for the risk factors and other issues, and she can follow the referral pathways to specialist and non-specialist. And of course, there are many treatments which will make you better. You have to take proper treatment. You will definitely improve your condition. Mental health condition will definitely improve. So be confident in the treatment. Be confident in the service provider. Come forward and seek help. So we have to evaluate evaluate what the condition is, what is the why she is feeling overwhelmed. That is the first and most important step in such a situation.
Dr. Thasneem?
Yeah, the most important thing is that let them speak out. Entertain them to speak out. That is the most important thing. And without keeping it and piling up all these emotions and suddenly getting into a syndromic level, encourage them to speak out. So that's counseling. We have to start from the antenatal period itself. Speak out. So that itself will help and encourage the family members to be good listeners to what they are pouring out, if at all. So that awareness, if we can create, half of all these problems can be decreased, if not eliminated.
Yeah, I think that's absolutely right, because I think people suffering, as I keep on saying, suffering in silence is not an option, because I think that creates more danger, more harm for the family, for the person itself as well. I think it's important to actually have a conversation. It's important to actually talk about that to your friends or your other people. And I think fearless talk on mental health and well-being is actually what is important there. The thing is that the fearless talk might be helpful even in the developed world. We have fearless talk, but we still have our own major issues. In the UK, we prescribe about 1.5 billion prescriptions for mental illness, and yet we haven't found an answer. But so it is not all I think there are issues in all parts of the world. So I think
there are misconceptions, certain stigmas, maybe in this part of the world, like a woman who has delivered just recently should not go out. They should not come out, or they should not take part in huge gatherings. There are some superstitions that is being carried on. But as Sir was discussing in the beginning, in mingling in art, taking part in art and all these things, let them do all these things. People sometimes used to say, don't read in your postpartum period, that will affect your eyesight. That is a very common superstition. Almost everybody, including doctors, me personally, have listened to such comments. You should not read. When you are reading, while you are reading, you just delivered. You should not read books that your eyes will be affected. So those superstitions will make them more caged inside, like they are not able to get into their hobbies or diversions like art, movies. All these things will not be watched. They are not supposed to watch TV. This the earlier generation people, they used to say, don't watch TV in your postpartum period until you're 40 days postpartum. Don't watch TV. It will affect your eyesight. It will affect your thoughts. You will forget about the babies. Those superstitions should be eradicated so that let them come out. So we used to say, because majority of the husbands are expatriates, especially in the Gulf countries, we used to say them, no, you ask your husbands. In the Middle East, people come, they deliver, and they go back and they do their job at home. So that's the same here. Women are same here also. You do all these things. So, but even if doctors, even if we tell them, no, you can walk, you can do your work, you can read, you can prepare for read exam. Even if we say all these things, people are reluctant to accept it. So that superstitions, if we change, women can have enjoyments from their maybe movies, from reading novels when the baby is sleeping. So that will ease their tension a lot. So it's caging inside because you have delivered a baby. That is something we should eradicate from our society.
Yeah. I think that's absolutely right in terms of you mentioned about arts, and I think arts and cultural heritage have a major role to play, both in terms of understanding some of those issues, finding solutions oneself, and also in terms of seeking help. And I think creative arts in whatever it is, music, painting, all those kind of stuff, and also spirituality, religion, a lot of other things can actually be helpful. And I think in terms of finding one's own solutions, and I think we shouldn't throw the baby with the bathwater. We have those cultural heritage that is actually very strong, and I think we must actually use that to the best advantage of promoting that health and well-being. Yeah, we have a question from Facebook, I think, by Professor Abbas Singh. Nowadays, women are actually having children after 35 years and above. Is it helping in mental health and well-being?
No, definitely young age or teenage pregnancy is a risk factor for mental health disorders. But also old age delivery is also a risk factor for mental health disorders. So becoming an aged like 35, after 35, if you become an elderly primary, I guess Dr. Fathima Thasneem, after 35, I think it is an elderly primary, right? So first pregnancy after 35 adds on to complications of pregnancy. So I don't think there is any advantage on mental health. Very young age pregnancy and very old age pregnancy definitely is a risk factor for mental health disorder. But after 35, I don't think there is any add-on benefits delivering after 35.
And that, I think that question comes up from the notion that maturity goes hand in hand with
Yes.
mental health. That is not fully true, I think so. Maybe because these mental health fragility during pregnancy and postpartum is because of some hormonal issues. Even if you have pregnancy at 20 years and 35 years, your hormones are same. The profile is going to be the same. So those women who are sensitive to this hormonal changes during pregnancy at any age, they can get all these issues. So, having a
young age pregnancy,
maturity
young age pregnancy,
that doesn't prevent you from a postpartum blues or postpartum depression.
Young age pregnancy is a risk factor because there is lack of support during that younger age, and they do not know what is going to happen. That maturity, if we talk in that sense, has some this thing like when it comes to younger age or teenage pregnancy, that is definitely a risk factor. But above 35, I don't think there is any add-on benefits.
Yeah, I don't know age is a barrier at all, because we had our third child when my wife was actually in 42, and I don't think that has actually played any role at all. So obviously age is no barrier, and I think we should try and enjoy them. And I think as long as people are prepared, there might be complications in relationship for some people, not for everybody.
Yeah,
I don't think age is a barrier.
with that question, within that structure of that question is the loophole in awareness. Because we have to let people understand that these hormonal profiles make you vulnerable for all these mental issues. It's not just simply that a mental issue is happening. There are some definite scientific evidence why a pregnancy is putting a woman at risk of all these issues.
Yes,
So that people should understand. When people understand that, at any age, people can give more support to all these women.
Yeah, thank you.
When talking about scientific,
sorry, go on.
when talking about scientific basis, what is happening actually is a drop in estrogen and progesterone, which in turn affect on dopamine and serotonin, which is the neurotransmitters responsible for this mental or psychiatric disorder. So we have to understand that it is the difference in the neurotransmitters in brain which cause this issue, not always all the psychosocial issues. So, but some are vulnerable. If some have some psychosocial issues, they are more vulnerable. That's all. But the disorder is due to some difference in the level of neurotransmitters. That is the thing people should understand. Or the illness is not made by the woman; it is happening to them. They are not guilty about it. It is not their fault. That is the thing people should understand.
Okay. Thank you. Thank you for that. There is a comment from again, Anjali Viswanath. She was saying about whether it'd be grateful we can suggest some guidelines and materials for supporting families. Is there any indication of that? Any kind of guidelines or any kind of cookbook approaches here that is readily available, downloadable?
Actually, I don't think there is a guideline. First of all, we should know what is happening to. We should get a, as we tell in medical, a good history. What is happening with her, and looking into like this guidelines and articles without proper diagnosis. If like she might be having just a postpartum blue, and if she thinks she's having postpartum depression, go through the guidelines of postpartum depression or postpartum psychosis, it is going to be bad for her. It is not going to help her. So it is if she is badly in need of help, it's better to approach a healthcare professional rather than looking for guidelines, because we don't know what is actually happening. We have to properly guide her. We cannot tell this guideline you can use, this guideline, without knowing her actual condition. So let her go and seek
Googling for a benign ovarian cyst ending up in anxiety regarding cancer.
Yes.
Just like that, she might Google regarding some anxiety will lead her to Google, and she might think she is psychotic. So it's better to.
Yes, recently I had a patient who came for medication for anger outbursts. She was having issues with her mother-in-law. She doesn't have any other issues, only anger problems. She was telling, when I Googled, I saw that I have postpartum psychosis, so I want medication. She came like, so it is always better to evaluate. If you have a doubt that there is something wrong, just seek help rather than going and Googling. That will be better.
Yeah, thank you for that. I think we have another question from Gatoki Busundar. Talks about are there any specific forms of psychotherapeutic approaches that one can take while working with new mothers at risk of PMADs?
Risk of
PMADs, it says. Presumably it's. Would you care to actually expand what PMADs is?
I'm not sure, sir. Yes, regarding psychotherapeutic issue, psychotherapies, there are definitely a specific type of psychotherapies. There is something called thinking happily. That is an WHO approved evidence-based method for postpartum depression. That is not actually not delivered by a specialist. It is delivered by a non-specialist. It is based on cognitive therapy. So definitely there are different psychotherapeutic approach. We can impart cognitive behavior therapy, cognitive therapy. She's having personality disorder, we can do DBT. There are many therapies which is there for postpartum
perinatal anxiety and depression, obviously. I mean, because we normally talk about postpartum depression, but not necessarily talk about anxiety. Yeah, Dr. Thasneem, anything?
Yeah, I'm learning from the psychiatrist what psychotherapeutic approaches we have.
Okay. We have also another question about what is the situation of research in this particular area, especially postpartum depression?
So the graph is going up, surely.
Yes, definitely.
Because the WHO had recently highlighted the importance of mental health, the general mental health as well as the maternal mental health, and we had the WHO motto, anthem for the last year, I guess, which is the mental health. So,
Yeah.
of course, all healthcare providers worldwide are being encouraged to think in terms of mental health for all their patients, be it obstetrics or any other department. And the maternal mental health has been in the limelight. Earlier, we did not have discussions like these regarding maternal mental health in any conferences. And as I told in the beginning, we didn't have a chapter in our textbook, the major textbook, which is the Bible of obstetrics. But then, over the past decade, we have had all these improvements in maternal mental health. Even the gynecologists are being during the regular postgraduate course. We do not stress upon maternal mental health. Once in a while, we might see a postpartum psychosis, which is very rare, as Anjali was pointing out, 0.2 to 1% maybe. And sometimes we may see a very evident postpartum depression. But other than that, as students, we were not sensitized towards this maternal health issues. But of course, recently we have had all these discussions. We are being sensitized to identify all these issues, and also the stresses upon the antenatal screening. Antenatal depression is also important. Earlier, even when a question is asked in university exam, what we used to write was about postpartum blue, depression, and psychosis. But now the antenatal depression, antenatal anxiety, stressors, the parenting stress, which might develop in the antenatal period, or which goes in connection with the antenatal anxiety. All these things have been come up. So we are all getting our awareness, improving and awareness, and of course the research is on the higher side. Of course, it is going up. The chart is going up.
Yes, research is regarding the medications also. Like everyone worry about the medications that are safe during pregnancy, safe during breastfeeding. There are researches, and lot of drugs are now considered to be relatively safe. We cannot tell completely safe because there are ethical issues in conducting researches in a pregnant woman and breastfeeding woman. So because of that, there are relatively safer medications for that. These are all due to researches which is happening. And also, Mental Health Care Act 2017 has given importance to maternal mental health by introducing an mother-child care units together for the care of mothers who need admissions, severe psychiatric illness which need admissions. According to Mental Health Care Act, there should be mother-child rearing units. And then Enhanced Bangalore has shown us that it is feasible because they had set up such an mother-child care unit which is running very well. So it is an example for all of us. We can also do that. Whenever a mother has severe psychotic symptoms, severe psychiatric illness, she need not be separated from the baby. Putting them together will benefit both of them, psychiatric illness of the mother as well as the bonding of the baby. So there are leaps in maternal mental health in terms of researchers and in terms of policymakers. Everywhere we are heading towards trend itself in terms of maternal mental health.
But I think can I may also add something in terms of the research that is an area that I have my expertise. So I think it's in relation to, I think we might actually have some of those issues in terms of service provisions, but I think very little in terms of enabling mothers to tell their own stories, because person with expertise is the best researcher, and they're the one who actually provide the best information. And I think studying storytelling about these things, in terms of how mothers and families may have overcome some of those things, in terms of resilience of some of those things, and how culture and society and how those actually shape up to the well-being of those kind of contexts. There is very little in terms of some of those researches in terms of the maternal mental health angle at all. I think mental health is very little poorly researched, but I think there are quite a few in terms of the medical aspects of things and also some of the service provisions, but nothing in relation to the more about the psychological context, the more of the family context, and how the social economic context can actually help, not in terms of the barriers. We have so much research of the barriers. What we want to have is actually more research on solutions, not barriers. That is an old story. We want more on solutions. We are progressive. We want to bring the young people and to come forward in terms of how to actually encourage that process. And how to provide again training for medical training and also allied professional training is an important area. How that is actually taking shape. Because actually in the UK, psychiatrists might actually can actually, before a medic and in the normal training might actually get 1 day or 2 day or a week of psychiatry training. That's all. Nothing more than that. And definitely go up and take up psychiatry as a psychiatrist. So I think it's important because mental health, there is no health without mental health. There is no, that slogan actually exists. But there again, majority of health and social care policymakers, governments, and providers don't actually stick to that process in terms of visualizing it and how to enable that into the kind of the context of everyday citizen, both in rural and urban context. And I think that is very crucial. So this is an area of fruitful research, purely from a user perspective, a carer perspective, and also from policy perspective. The policy is actually there. Are the policies actually working? Are the policies actually working for the benefit of the citizen? Because there is no point in actually having a policy if it doesn't work. So obviously there are contentious areas here as any of those things. Right. So any further questions or comments? We are actually into the last 10 minutes. We're having an interesting conversation. So obviously it's an enjoyable context in terms of, it's been very nice to have you both to talk about it freely and energetically and with passion. And I think that is very important. I think we need more of these conversations, isn't it? Not in terms of how, because there are solutions that we have to together develop. We cannot rely entirely on policymakers and the government to actually get everything. That doesn't actually happen in any of those countries, even in the welfare states, countries like ours here. But I think it's how we can bring together people, how we can connect with people, and how we can network with people to share that knowledge, to share that expertise, and to also to admit that we don't know something, and I think to understand, to learn more. Nobody is actually is full of knowledge in these kind of areas. Sometimes we have to think outside the box and imagine the impossible to see how some of those things we can actually implement or materialize, and try to implement some of those policies and dimensions. And I think that's what, in the Indian context, obviously, how were the young academics and young medical practitioners, young psychologists, young social workers, young everybody, and I think it is not, because the mental health literacy is not just for health professionals. Mental health literacy is for all of us, and I think that is actually what makes our health and well-being. The much more bring it to the real context of everyday life. So a last word from both of you, Dr. Fathima.
Yeah, so that's as Sir was winding up. It is nice that there is a collaboration between gynecologists and psychiatrists as well as psychosocial workers. And so let this be a beginning, and let it continue and expand, so that we can have a uniform mental health analysis for all obstetric patients throughout the state and the country. So that just like we have reduced our maternal mortality, neonatal mortality, all those indicators, we have to reduce the mental health problems during pregnancy. So the challenge for us is to make it uniform, make it a pattern, and the system to get in track. So that's it. We have to develop upon it. Maybe we can do in maybe 5 years or 10 years to come.
Thank you. Dr. Anjali?
Yes, sir. It was nice talking. It was, as you told, it was an energetic conversation. And yes, the holistic approach is needed. As now a psychiatrist, a gynecologist, social worker, psychologist, everyone can uniformly work for promoting mental health. And a holistic approach, including policymakers, then healthcare workers, everything unitedly work for a betterment of maternal mental health. That's it.
So thank you very much for both of you, Dr. Anjali and Dr. Fathima, for coming on board in your busy schedules and having this conversation with us. Do follow us. We have this MeHeLP India project in Kerala. and we hope to expand on that later on. But I think hopefully I will be in touch with you both about that. As to how we can actually, bring collaborations and bring connections and networks in relation to that. So thank you everybody who actually joined this webinar on maternal mental health literacy. I'm sure we would actually have some more conversations on the same topic. Professor Prabha Chandra has actually agreed to talk about it at the end of May, so we will have another webinar on perinatal mental health towards the end of May. So this topic is actually going to carry on. So thank you very much for joining. Our next webinar, hopefully towards the end of this month or early May, would be on psychiatric pluralism in India. And I think so we have the allopathic Ayurvedic dimensions of how we look at mental health and well-being, because it is the richness of it. It is how we actually look at the medical pluralism, but it's actually very much important. So we have, we will watch the space. We'll have a date for psychiatric pluralism towards the end of the month. So thank you very much. Thank you, Parvati, for hosting this webinar. And I'll be in touch with both of you. And thank you ever so much for taking the time, especially in this fasting time, Dr. Fathima, and to come on board, and also Dr. Anjali to help us in terms of having this free conversation, mainstreaming mental health conversation. Do follow her. Do follow us on our MeHeLP Facebook page and YouTube and also on our web in relation to further information. Many thanks and have a good evening.
Thank you, sir. Good evening.